Welcome to part 2 of this introduction to lung POCUS. In this section, we will be focusing on normal and pathological signs with a particular focus on pathology. In lung POCUS, there are three main areas to be assessed for pathology. The first is the pleural line, as you can see highlighted in the yellow box. When looking at the pleural line, we want to identify one, if there is sliding, and two, whether or not the pleural line looks regular or irregular. The second area is the interstitium, which can be seen in the yellow box here. And as we'll get into it, we want to identify a pattern, whether it's an A-line pattern, B-line pattern, or consolidation. And then the last spot we want to look at is the pleural space, as highlighted in the red box. And in this, of course, there's no clear effusion, as we'll explain later. But this would be the main thing that we're looking for in the pleural space, is an effusion. Focusing in on pleural line pathology, and specifically the assessment of lung sliding, we see on the left video the shimmering appearance of the pleural line, particularly with respiration, and this is a very good example of lung sliding. In the middle video, we see something similar. However, the shimmering appearance appears to be synchronous with the heartbeat. Both lung sliding and lung pulse indicate that there is movement between the visceral and parietal pleura, and thus we can essentially rule out a pneumothorax at that site of the exam. On the right hand side video, we see something quite different. The pleural line doesn't shimmer, and thus it has absent lung sliding. Now, absent lung sliding is not specific for a pneumothorax. If we wanted to try and diagnose pneumothorax by ultrasound, we need to find something called lung point, and that will be described in another video. Just to note that anything that would cause adherence between the parietal and visceral pleura, particularly anything that would introduce fluid or pussy material, like a pneumonia or post-pleurodesis, would cause absent lung sliding as well. In cases where it's unclear whether or not there is or isn't lung sliding, we can use the M mode to help us distinguish this. Looking at the video on the left-hand side, we see what we call the seashore sign. At the top of the image, we see what looks like waves, and we call that the sea. At the bottom, we see a grainy appearance, and we call that the sand, and hence it looks like a seashore. The presence of a seashore in M mode is indicative of lung sliding, and you can see that again looking at this left-sided video. At the top right of it, there is a image that shows the same exam, but in 2D mode, and we can see very clear shimmering appearance of the pleura. In comparison, on the right-hand side, we see what looks like a barcode, and hence why it's called the barcode sign. This is indicative of absent lung sliding, and again, looking at the top right-hand side of this video, we see again a 2D image, and in this 2D image there is absent sliding. Moving on to the next assessment of pleural line pathology, we'll look at the regularity versus irregularity of the pleural line. On the left-hand side, we see a nice, smooth, continuous pleural line. In comparison to the middle and right-hand side videos, the middle video, the pleural line appears jagged, and in the right-hand side video, we can see during certain areas of the exam that the pleural line actually is fragmented or discontinuous. And why this matters is that it can help us distinguish different pathologies. As we'll get into at a later slide, these all have what we call B lines, which are indicative of interstitial syndrome. And depending on whether or not the pleural line is smooth and regular versus fragmented or or irregular, this can help us differentiate out possible causes, with CHF typically being associated with a regular pleural line and interstitial lung disease and ARDS being associated with irregular and fragmented pleural lines. Moving on from the pleural line, we will next discuss assessment of the interstitium and looking at interstitial pathology. To start this, we'll just review normal interstitium, which is defined by the presence of A lines, which was discussed in the first video. Just to recap, A lines demonstrate that the interstitium is normal and the lung is aerated at that point. A lines are equidistant repetitions of the pleural line. So as you can see in the video on the right here, the pleural line is approximately 1.5 centimeters from the probe at the top, and thus we see that the next A line is at around a little over 3 centimeters. So it's equidistant. And we can see further reverberations of that below. We don't need multiple A lines, we only need one A line to call it a A-line pattern. Pathologic interstitium is usually identified by the presence of B lines. B lines represent filling of intralobular or interlobular septa with fluid usually. The B line is defined by 5 key features. In the video on the right here that you can see, they are ray-like, hyperechoic, and vertical. They emanate from the pleural line at the top here, and they never come from above. They move with lung sliding, as you can see in the video. They extend to the periphery of the far field, and usually we want at least 18 to 20 centimeters ideally, and see that these B lines extend all the way to the bottom. And if there's any A lines, that they obliterate the A line at that point. For a interstitial syndrome to be present, at least 3 B lines need to be visualized between adjacent ribs for us to call this interstitial syndrome. And we'll get into the causes of interstitial syndrome within the next couple slides. Before we move into causes of interstitial syndrome, it's important to distinguish false B lines from true B lines. As discussed in the previous slide, there are 5 key features, and we do want to make sure that we identify those 5 features before we call a vertical artifact a B line. As you can see in this slide, the most common false B line is something called a Z line, and this is shown in an image by Lichtenstein. And these don't have any pathologic significance. The key distinguishing feature between Z lines and B lines is that Z lines attenuate before the periphery of the screen. They are less echoic than the pleural line, as you can see here, and they're not as discrete. There are actually a number of different false B lines, and I won't get into all of them, but this image from Lichtenstein et al. Demonstrates the sheer number of different vertical artifacts that exist that can mimic B lines, but again are not indicative of interstitial syndrome. Interstitial syndrome has been defined by international consensus guidelines, and this is highlighted in this yellow box here. Essentially, as mentioned before, we need at least 3 B lines in a longitudinal plane between 2 ribs, as can be seen in all of these images here. And to define it specifically as interstitial syndrome, we need to have at least 2 positive regions bilaterally. Now, the causes of interstitial syndrome are variable. The most common one that most people think of is pulmonary edema. However, both ARDS and DPLD, or interstitial lung disease, are also possible etiologies of interstitial syndrome. If B lines are not bilateral and diffuse, but rather focal, we tend to think of other causes like pneumonia or pneumonitis or atelectasis or some of the other causes highlighted in the box here. Finally, on looking at the right-hand side, when we do see interstitial syndrome, there are some key features that we can use to help distinguish pulmonary edema from other causes like ILD and ARDS. In particular, cardiogenic pulmonary edema, as we talked about in the pleural line assessment, the pleural line should be regular and smooth, and this can be seen here in image B versus interstitial lung disease, where the pleural line tends to be fragmented or irregular, and this can be seen in image D here. And also the B lines tend to be non-homogeneous. They tend to be a bit scattered and in only specific areas, as can be seen in image C. The other possibility is ARDS. In ARDS, again, we do see an irregular pleura. The B lines are non-homogeneous, and sometimes there are spared areas of normal parenchyma that we typically see. And also there may be some reduced lung sliding present. The last pattern that can be identified in the interstitium, that's pathologic, is consolidations. To identify a consolidation, there are a variety of different signs we can look for. The first is hepatization, and with hepatization, we are trying to find an area of the lung that looks similar to that of the liver, and you can see that highlighted here in yellow. The echo texture of this area of lung is similar to that of liver, and this is because the lung is consolidated and thus takes on a tissue-like echo appearance. The other sign that we can look for is called the shred sign, and this is an irregular shredded border, usually at the deep edge of the consolidation, and you can usually see aerated lung below this, and it can take on either an A pattern or a sub B pattern. And the last sign that we can see is called the spine sign, and I'll get into this in the next slide when we talk about effusions, but the spine sign is when we can see the spine above the diaphragm. Typically we can't see the spine when there's just aerated lung and there's no consolidation. And so if we see that, that's another indication that there's a consolidation pattern. Once a consolidation is identified, we next want to look for the presence of air bronchograms, which is essentially air that is trapped within terminal bronchioles due to the consolidations. The air bronchograms on ultrasound appear as hyperechoic punctate or linear lesions. They can either be static, as seen in the left image here, in which case there is no movement aside from that associated with lung respiration, or they can be dynamic and they move independent of the lung movement, as seen here in the right image. If we find dynamic air bronchograms, they are pathognomonic for pneumonia. In contrast, static air bronchograms can be associated with pneumonia, but are also associated with other pathologies like atelectasis. Next, the last area that we want to assess for pathology is the pleural space. And specifically, we want to see if there is the presence of an effusion. Now, an effusion, typically the best area to try and identify it is at the PLAPS, or the posterolateral alveolar syndrome area, as described in the first video. And an effusion is defined by the presence of several signs, but the most notable and most commonly used is the spine sign, and is shown in the bottom yellow box here. And what this is the spine extends above the diaphragm. In normal lung, we would not normally be able to see the spine superior to the diaphragm. However, when there is fluid or consolidation, the ultrasound beam is able to penetrate through that fluid or consolidation and bounce off the spine, thus making it visible, as compared to normal aerated lung. The beam is dispersed and it never makes it to the spine. The other possible signs that can be seen is the quad sign, in which case we see a hypoechoic space limited by the pleural and lung line, as shown in the video on the right here. And the last sign is the sinusoid sign, and really all this is just we see the distance between the lung and pleural line decreasing with inspiration. And that wraps up this section of the lung ultrasound introduction. Here are the references that were used for this section.